The presentation on dementia and elderly. All of you, I hope, must have already got the material and gone through it. You people have already completed at least one of these spells. And so you may be familiar with taking the history and examination in the neurological history and examination, and you may have also gone through dementia or some kind of Alzheimer's or some kind of a disease associated with dementia in some part of the module, because many of the modules is covering it in some way or the other. Either it is being covered as elderly abuse, it is being covered as caregiver stress, or it is being covered per se as the disease. So over here we are going to discuss it comprehensively about dementia in elderly, that what is dementia in elderly, because many times we get confused between old age and dementia per se as an illness, because many times the people do tend to forget, elderly do tend to forget, and we say, yeah, this is quite normal in old age, so don't think that it is something abnormal, this is because of the aging process. So I would like Dr. Debashish today, when he will be making his presentation, to tell us when exactly do we say that this is dementia. Is dementia a normal aging process? Is forgetfulness a normal aging process, or is it something which needs to be further investigated into? So these are the questions I would like Dr. Debashish to answer when we will be having his presentation, and I would also request you to ask questions so that we know that you are there and you are comprehending whatever is being taught to you, and we will be happy to know how many students are attending in each of the centers. Thank you.
Thank you. Good afternoon, everybody. So see, the dementia is often considered as a disease. But let me tell you, dementia is not a disease. Dementia is a group of symptoms. The term dementia, demens, it's a Latin origin term meaning without mind. This has been used for a long time, since 7th century. The first description by Thomas Willis, who described the circle of Willis in brain, came in 17th century, who described the post-apoplexy, that is post-stroke dementia. But the landmark changes in our understanding of dementia actually started from the illustrative case of Alzheimer, who described the changes in a female who was around 54 years of age. Now, consequently, over a period of time, two concepts came. One was called the pre-senile dementia, and one was senile dementia. Now, usually, the pre-senile ones, that is, those occurring in patients who are less than 65 years of age, was assumed to be because of Alzheimer's disease, and the senile dementia, as Dr. Ruchika was telling, that was felt primarily because of the atherosclerotic changes, and then they were referred to as vascular dementia. That's something happening in the arteries of the brain of these persons, and that's why they are getting dementia. But these concepts were under a review, a scanner, went under a scanner by 1960s, because by that time, lot of pathology became available. You know, the patients who died of dementia, their brains were opened up, they were sectioned, and they were seen as a gross structure and also under microscope. And the molecular basis of the various abnormalities that were detected were analyzed. And the degenerative pathology was considered primarily responsible both for pre-senile as well as senile dementia, and therefore the nosological status of vascular dementia became uncertain. But then again a change came. By late 1970s, CT scan and MRI came up in a big way, where you could see the brain in totality, you could delineate the structures, you knew about the arteries, you knew about the areas, and you could see the pathology, like you could see the infarctions, you could see the hemorrhages. So all this became very exciting, and our concepts kept on changing. Now see, this is the brain of a patient with Alzheimer's disease. Normally, you see that the sulci and gyri are not separated so much. There is a volume loss in the center. This is a comparative study. On the left hand side you see a normal brain, and on the right hand side, you see the brain which is shrunken, and there is this gutters which have been formed because of the atrophy of the brain. So this is suggestive of Alzheimer's disease. Then neuropathologically you could see that there were small aggregates of cells in this fashion with specific staining. As you know, they are called the beta amyloid, and then there was these small tangles which were formed. They are called the fibrillary tangles. These became the pathological hallmark of Alzheimer's disease, and so the disease could be easily distinguished from so-called vascular dementia cases. In contrast, if you see, this is an acute stroke infarction with a hemorrhagic conversion. The embolus has gone and lodged at the top corner of the brain, producing an area of necrosis, and there is a lot of surrounding edema and hemorrhage within. So this also, when happens either in a strategic location or happening all over the brain in multiple series of recurrences, can produce dementia, which is known as vascular dementia. This is again another hemorrhage. Now there are two areas. This is one hemorrhagic infarction which has happened, and this is another hemorrhagic infarction which has happened. And then there is another small one involving the deeper structures of the brain. And if you see, there is an old one which has become quite necrotic and gliotic. That is, that as you damage your tissues outside your body, like on your skin, you develop a scar. So this develops as a scar in the brain. But all this adds up to an effect in the mental abilities of the patient, resulting in dementia. So this is the example of vascular dementia. And sometimes a strategically located, suddenly a huge gush of blood runs in the thalamus, the blood vessel ruptures, and this is the strategically, because this is the thalamus. Thalamus is called the inner chamber. This modulates all our sensory information, and through this relay station, the sensory inputs go to the cortex. Now this area gets devastated by this large hemorrhage. So this patient, although the rest of the brain is okay, fine, but still the patient will have symptoms and signs of dementia. So these are called strategic dementias.
Before you go ahead, Dr. Devashish, I would like to ask you a question that you said that these are because of the atherosclerotic changes. Those people who have atherosclerosis in their cerebral vasculature, they are more prone to have it. Now, it is very difficult for us clinically to find out in a living person whether there are atherosclerotic changes in the brain or not, unless we go in for the various investigations. But a person who is having changes in the cardiac circulation, that is, he is having atherosclerotic changes, because many of us are very much aware that with the in the elderly there are more chances of a heart attack, there are more chances of atherosclerotic changes. Do the atherosclerotic changes in the cardiac vasculature reflect atherosclerotic changes in the cerebral vasculature?
Yes, by and large it does. Most of the patients who are having this coronary artery disease or ischemic heart disease, as we say them, they also are more prone to have increased chances of having either ischemic or hemorrhagic stroke. But the determinants are maybe different. In stroke patients, the hypertension is the single most important determinant, uncontrolled hypertension. So that is an important determinant in elderly patients. So in earlier days, it was believed that both systolic and diastolic are important. But now we are having the recent data in which the systolic is probably more important. And earlier, doctors used to say, okay, if your upper blood pressure limit is all right, then you don't have to bother. But you do have to bother about the systolic hypertension also. Now, this is the second scenario happens, as we talk about the atherosclerosis, that involves the large arteries. But what about the small vessels which are supplying the deeper structures of the brain? They are called end arteries because they don't have any collateral communication with each other. So they produce these small holes nodules which are called lacunes. And you see in a patient, these multiple lacunes are formed, and these, when they add up to a large total, they also produce a dementia of vascular origin. So vascular dementia actually encompasses a lot of terms, unlike Alzheimer's disease, which usually will follow a definite pattern. But there may be a miss, because elderly patients are more prone to have atherosclerosis, more prone to have all these risk factors, and they are more prone to have Alzheimer's disease. So there may be a subset of people who will have both Alzheimer's disease with vascular risk factors, and at times it becomes very difficult to distinguish between these two subsets.
But is there okay, we can finish with the
Okay,
pathology first.
and now as I was telling, the MRI has really revolutionized. We don't have to cut the brain to know this. We now know that with the MRI you can see the large areas of infarcts having both the temporal lobes involved in this patient, and then we have this small lacunes I was telling sitting bilaterally on both the sides, and then there is this white matter tracts, they are involved, and so these are the patients who are likely to have vascular dementia. And at times it might become very, very large and confluent. You see that there is the entire area around this ventricle. This is the lateral ventricle, and around this ventricle these areas are damaged, and they probably impair the conduction of a lot of information through the higher centers, and therefore they cause dementia. And also MRI techniques have been available now, with which we know that there has been old hemorrhages, otherwise we will not be able to pick up. These are the small old hemorrhages, and that might be the cause of dementia in some patients. So now let us come to the fact that what is dementia after all? Dementia can be said to have a progressive deterioration in intellectual function and other cognitive skills, leading to a decline in the ability to perform activities of daily living. So there is a loss of mental functions such as thinking, memory, reasoning, that is severe enough to interfere with a person's day-to-day life. Dementia is not a disease itself, as I said, but it's a group of symptoms that might accompany certain diseases or conditions. And moreover, these symptoms might also include the changes in personality, mood, and behavior. Dementia is irreversible when caused by a disease or injury causing loss of neurons permanently, but it may be reversible when caused by drugs, alcohol, hormone or vitamin imbalances, or depression. So therefore, in dealing with patients with dementia, the first task of a clinician would be to differentiate that whether we are dealing with an irreversible dementia or it's a reversible dementia, because that is eminently treatable or correctable. The most common cause of dementia is Alzheimer's disease. However, now, as you know that in India, we have a large number of diabetic patients, large number of cardiac patients. So therefore, there is a possibility that in future we might be having more of vascular dementia, because these are the patients who are going to have more problems if these risk factors are not controlled adequately.
This is probably because of the increase in the longevity, because these patients will be living for a longer time.
Definitely.
So would you mean that in Alzheimer's case will be less in India as compared to the West?
Till now, the data which are available, it has shown that Alzheimer's disease patients are surely less in number in India.
But that may also be because of the stigma attached to it. People do not come up for diagnosis, do not disclose that they have a dementia.
That might be because of that selection bias. Most of the patients do not come to the hospital for checkup. And many a times in villages, for example, the elderly persons are kept like that. But still, the overall picture suggests that Alzheimer's disease may not be as common as in the West.
Genetically, they are not.
Genetically, probably Indians have some protection, possibly, for Alzheimer's disease. But we need to verify that with a long and large epidemiological study.
Doctor, you talked about the intellectual disturbance in dementia.
Right.
How about the emotional aspects?
Oh yes, mood. Mood changes, emotional lability. That is one of the hallmarks in such patients. And especially in the early stage of this Alzheimer's disease patients, when they know that they are not able to function properly, they get very agitated. Their moods become very labile. Sometimes they start shouting, sometimes they behave in a strange manner, sometimes they go out of the house, they have a wandering behavior. So this definitely affects the personality, the mood and the behavior. Now, as we all know that dementia is primarily an aging problem. The prevalence of dementia doubles every 5 years after the age of 60, and as the demography of India is changing, so therefore we are likely to see and encounter more and more such patients, and we have to seriously think about the medical aspects, the social aspects, the family aspects of how to deal with these patients.
I want to ask you one thing, is it that dementia occurs after 60, or is it that dementia is diagnosed after 60?
That's a very difficult question. You see, that is precisely when actually the symptoms of dementia develop and when the patient presents to a doctor, but at that time it is reasonably late period.
Yeah, because the type of symptom complex that you have told for dementia, forgetfulness, the activities of daily living being affected because of the cognitive functions, it is very difficult to evaluate cognitive functions in an individual. The cognitive functions being so individualistic and so variant, I feel.
Right. So that's the reason now there is a concept which has come, which is called MCI, minimal cognitive impairment. A person might be having just early signs, early symptoms of the disease, and this is the group we should focus upon and see how these people progress over a period of time and whether we can do something to reverse the degenerative process. A lot of work is being done in that regard.
Yeah, I would request that we can just have the facts and the phone numbers also displayed on the screen, because we would like to invite certain questions. We have not been getting any questions from the students. Kindly please ask the questions. I know that the presentations are highly engrossing and very, but we would certainly like to have your interjection, so that, because Dr. Debashish has got such a vast amount of knowledge that if he knows that in which area you would like him to steer his conversation, it would be much simpler for him, and we would like to focus on those issues which you would like to discuss, because all this, dementia is a very vast topic, very vast topic, and so it is better that we focus on those problems which you may be facing day to day, or you may perceive that you may face them in future. Thank you. I think.
Right. See that you have to understand that there are three components in the dementia spectrum. One is the cognitive deficit, one is the behavioral aspect, as Dr. Sairam was suggested, and third is what is the impact of these two on the functional ability of the patient. So cognitive, behavioral and functional. Now cognitive is the mainstay for diagnosis because it encompasses 5 different functions, the main functions of cognition. What? First, the memory functions. So these people have defects in the memory, which is called forgetfulness in simpler words and amnesia in scientific words. They have problems with language. They have difficulty in speaking and understanding, which is known as aphasia. They have difficulty in recognizing, so that is called agnosia. Gnoso is a term which means recognition. So agnosia, failure to recognize. Then we have a term called apraxia, that whatever the movements, the motor movements which we do, human beings do, are all learned over the years. And these people forget the learned motor movements. How to perform a simple motor task like taking up a glass of water from the table, how to salute, how to whistle, how to shave. All these come under the purview of praxis and they are called apraxias. And finally, the highest function of human beings, that is the functions of the frontal lobes which requires planning, anticipation, that is called the executive function. So all these parameters may be affected either in combination or in certain patterns to produce different dementia symptom complex in a given patient.
But there is no set pattern in which they are affected, that one aspect is affected before the other.
Yes, they are not, but in some, say for example in Alzheimer's disease, the amnesia part and the aphasia part are usually early to occur and the rest of the loss occurs slightly late. Whereas in vascular dementia, the executive function loss is a prominent feature early on, whereas the memory loss often happens quite late. So these are the patterns by which you can differentiate. Now if you go by this criteria, I don't want you to note in detail, but one thing important, the criteria requires that to tell it as a dementia, we should have one, memory impairment, and at least one of the rest of the following, either aphasia, apraxia, agnosia, and executive. So memory impairment is a must, even though it might be very subtle.
Yeah, can we have the slide? I think it's important for them to. Can we have this slide, please? Yeah.
Yeah. So memory impaired and at least one of the following. And this should affect their day-to-day living. And this should be severe enough. This decline should represent from a previously relatively normal level of functioning. And the patient should not be in a delirious state or under severe depression to diagnose the patient as dementia, because they can also show the similar features. Okay, so this is the main crux of the things. Now let us briefly go into the memory impairment. Memory has got three categories. There is the immediate, the recent, and the remote. Now as you all know that some information is given to you, immediately your brain catches those information, and then it has to really consolidate that information, and later on whenever you require that information it has to retrieve it. So these processes primarily are important in the generation of memory. I will not go into the details of this, but it is important to know that there are three types of memory. One is the immediate or the working memory, as I said, by visual cues or by auditory cues. Then there are recent new learning memories, in which there are certain explicit or declarative events which goes to your brain and gets encoded. And then there are remote or long-term memory which remains in the brain forever and you can retrieve it. Mind you, the dementia patient usually will retain the remote memory for a long period of time. So the patient will start talking about his past, what had happened 25 years back, 30 years back, but he will not be able to do well in this immediate and the recent learning patterns. So I think this is important to know that immediate working memory requires one important thing, that is the attention. If you are not attentive, for example, if you are not attentive with this lecture, you will hardly register any of this information, and probably in an hour or so it all get washed out. So attention and sustained attention, which is called vigilance, is very important for immediate memory. The recent memory can be divided into three types. One would be the episodic memory, that it lasts for minutes to months. The normal individuals will lay down multiple episodic memories throughout the day, which allow them to move through the life connected with previous experiences. And for that, the main part of the brain which is important is hippocampus. And in Alzheimer's disease, this hippocampal atrophy occurs. There is slow degeneration of hippocampus. So therefore, the day-to-day working becomes much difficult for these patients. Also involved are the medial temporal lobes for this kind of memory. Now eventually these episodic memories become independent of the hippocampal complex and move to the neocortex, that is to the higher part of the brain. From the deeper structures is going to the neocortex, that is the newer cortex which human beings have developed over the evolution, so that it's stored as a long-term memory. Then comes the semantic memory. Semantics means the meaning. When you know the meaning of a thing, then obviously you memorize that thing well. So there is a particular process by which the memories which were acquired earlier given some meaning and the person knows them by the meaning. This is called the semantic memory. And then comes the explicit memory. This has four stages, as I told you. First, it has to be encoded. The information goes there, the coding occurs. Then it has to be consolidated. And third, it has to be stored properly. And fourth, it has to be retrieved whenever you need that. I will not go into details of these processes, but in contrast to this kind of memory is another type of memory which is called implicit memory. This is a non-declarative memory, or as we call as procedural memory. For example, an Alzheimer patient, if you ask him what is a bicycle, he will not be able to say. What is its use? He will not be able to say. But if you give him a bicycle, he might ride on it by remembering how to ride the bicycle, because he knows the procedure. So this is the procedural memory. And this memory does not require a conscious search from the mind. It builds up slowly through repetition, and it is expressed in performance but not in words.
I think a good example would be driving a car.
Yeah.
Because then you don't have to think when you have to press the clutch and change the gear and then press the accelerator. I do not know, maybe.
So in Alzheimer's disease, this implicit memory can be retained for a reasonable period of time and may be made use in therapies.
Doctor, I have a question on this memory improvement, because there are memory enhancers in Ayurveda, like centella and other things, other herbs. They claim that, they improve memory and all that.
Right.
Is there any possibility of doing any such, including such memory enhancers, so that the memory could be improved? Do you have you come across?
All over the world, people are searching for this drug which will enhance the memory. Unfortunately, the memory, this is just the physiological process I am talking, but if you see the biochemistry of it, it is very, very complex. We yet don't know that what are the actual chemicals, what are the neurotransmitters which are basically been involved in these various processes, and how these drugs are going to interact with these neurotransmitters and how they are going to enhance these processes. They need a lot of research. There are some positive research directions in that regard, but yet it is in a nascent stage.
Another question I wanted to ask, that we are very clear about Alzheimer's, what all is defective and what all is not. Vascular dementia affects memory or does dementia, but then I think the location of the vascular injury would also make a difference as to which kind of memory would be lost or not, because the different kinds of memories are in different lobes.
Yes. See, that another way of differentiating memory is by the cortical involvement versus subcortical involvement. Alzheimer's disease is primarily a cortical disease. That is, the cortical areas are involved. Whereas the vascular dementia is a prototype of a subcortical disease. Subcortical means where the neuronal networking is going on. The white matter tracts are there. So in this case, the memory impairment occurs, but most of this patient improves on cues.
Yeah,
if you give them the cues, they will recall. Whereas Alzheimer's disease, if you give them the cues, even then also they are not going to improve. So this is the fundamental difference. And because these tracts are involved, in the vascular dementia patients, a lot of motor disturbances will be there. There will be difficulty in walking, there will be difficulty in handling things, there will be difficulty in performing the day-to-day routine activities like bathing, because of the motor weakness or the motor problems.
Doctor, there are some organisms like unicellular amoeba and all. They don't have this specialized mechanism of memorization and all that, but even brain, for instance. So in such organisms, do you think that this type of, if we do some research with certain chemicals and all that, to find that whether there is some sort of behavior pattern could be changed, whether it's possible any such?
Oh yes, from the lower unicellular organism to multicellular organisms, a lot of research experimental models have been created, dementia models have been created. But the problem is that you cannot always extrapolate entirely the animal data to human beings, because we have, in the evolutionary scales, we have developed certain features which are unique to us. For example, our frontal lobes are much, much bigger than the other animals. So in earlier years, nobody gave any damn thought about what are the functions of frontal lobes. Only in the last 50 years, we came to know, no, they are very important. They are responsible for the executive function, the planning, the rationale, the judgment, the abstract thinking. All this is generated by the frontal lobes.
So actually what you're trying to tell us is very important. I think that on history taking itself, if we take a meticulous history, we can get an indication whether it is a vascular dementia or probably an Alzheimer's
Yes,
disease.
definitely.
Which is very important because vascular dementia is to some extent manageable and treatable, and further episodes can be prevented, whereas Alzheimer's disease we can do nothing except do symptomatic management.
Yes.
So I think from management point of view, it's very important for us to take a very meticulous history and know that, which are the specific questions to be asked for.
Correct. That's very important. Aphasia, you know that it's considered to be as a disorder of language, and that has two components, the motor component and the sensory component. But it is entirely this perisylvian area which is involved in the language functions, and they are disturbed in Alzheimer's disease as well as in vascular dementia. But the changes are different. Now, we examine the aphasic patient, we see the spontaneous speech, we ask for their comprehension, we ask their naming abilities, we ask the repetition, we ask the reading and writing part, and therefore we conclude that the patient's language is not proper.
Is there any difference between Alzheimer's and vascular dementia as far
Yes.
as this is concerned?
Alzheimer's disease patients will usually have comprehension deficits, whereas vascular dementia patient may have comprehension deficits as well as the speech output deficits.
And what
So,
do you exactly mean by comprehension deficit in speech?
comprehension deficits is this, that when the patient speaks, the patient will speak lot of, use lot of sounds, but mostly they will have
No
meaning.
meaning.
No meaning. So that will be considered as a jargon speech by most of us. They may use new languages, which is known as neologism. So this kind of thing is more common with Alzheimer's disease patients, whereas the output problem is more common with vascular dementia patients.
Output would mean what?
Means that the patient will not be able to say, pronounce
Okay.
the words itself. Their sentences may assume a telegraphic character.
Yeah.
I went bathroom.
Okay.
Devoid of any verbs and conjunctions.
Okay.
So this kind of thing is more common with vascular.
I think we had gone to some conference on dementia, and there was one relative who was, trying to tell that her mother had Alzheimer's, and so she found, as you're rightly saying, that there is substitution of the words which are being used. So she tried to maintain a diary in which, for example, if she meant glass, then it would probably mean water. So she tried to maintain this diary, but then soon she realized, that the dictionary needed revision every second, third day, because one day the glass would mean water and the second day probably a cylinder would mean water. So I think that is what is meant by.
And it is very difficult to manage such patients because you are not able to communicate, because he is not able to comprehend you, and you are not able to comprehend using your normal vocabulary. The apraxia can again be divided into three types: the limb kinetic, ideomotor, and ideational. Without going into the details, it is basically inability to use your body parts properly.
I think we have only 10 minutes left, and I would request the students that kindly ask questions, whatever you want to ask, because we should take advantage of the experts who are here. Difficult to get them, and kindly ask whatever questions you have, and the regional directors may also inform us how many students are attending the teleconferencing. Thank you. Yeah.
Then come the agnosia. As I said, all the sensory modalities can be misrecognized by these patients. The most common is the visual agnosia. Like this patient who has drawn on command, copied it, but he is not able to identify the key, the pig or the bird. And then also, sometimes the patient may identify the individual objects in a picture, but when taken in totality, that simultaneously, what is the meaning of this picture? For example, this is a famous cookie theft picture in which the person may say there is a woman standing there or there is a boy on the table, but he will miss out the entire scene as a total concept. So this is called simultagnosia. Say for example, this person will never be identified, instead all the fruits and vegetables will be identified. And finally, the executive functions. As I said, planning, organizing, selective attention, problem solving, initiating anything, inhibiting something, self-monitoring, abstract thinking, and mental flexibility. All these are executive functions. And they are the complex functions that allow one to engage in effective and efficient goal-directed behavior. And when they are lost, then we have a lot of these problems. For example, when drawing on command a circle, this is drawn like this. And when we ask the patient to sort out the cards by color, shape or number, the patient is not able to. And then this is a famous Stroop test in which we ask the patient to identify the color and spell it. Patient is unable to do that. And then this trail making sense, in which the person is asked to connect A to B to C to D. Normal person will very easily do it, but an Alzheimer patient will have much difficulty, and it can be made more difficult by adding 1 to A, then 2 to B, like that, and this is the trail making test B. This becomes further difficult.
These are all the symptoms in an Alzheimer patient,
right,
which will not be found in a vascular dementia.
No, the vascular dementia patients may also be found, but they are found at a later part of their illness. In Alzheimer's, this might be the early part which might be found. So, summary is dementia is a symptom complex. Elements of dementia has various causes. All the elements may not be present in all cases. Complex testing procedures but crucial for diagnosis, and many dementias are treatable, few are reversible. So this is generally the idea, because I have not dealt with the treatment part at all, because itself it is very important to know what is dementia. Dementia is considered as a disease, but it's not a disease, it's a symptom complex, and you have to have these findings to label a person as demented.
Yeah, it's all the more important to recognize dementia, because
Right,
treatment is not that available also, but
right,
to be able to recognize dementia so that it can be managed, the symptoms can be managed, are I think very important. So I think it's we've got a very good comprehensive idea about what is dementia, and I think Dr. Debashish has also requested that he would like to present a very interesting case presentation related to our first topic, and that was on music therapy. So we would like to hear from you.
Yeah, I'm going to tell you briefly about a famous musician who suffered from the problem of dementia and how his career got affected. You know, it's titled as The Strange Illness of Maurice Ravel. If you are, listeners of Western classical music, you must be knowing that Maurice Ravel is one of the famous musicians of Western classical music, contemporary composer, and he is basically, basically revered for his extreme control over the notes, precision, and the beauty of his compositions. And there are various articles written on his life and on his strange illness. There is a film also made on Ravel's brain. His father was of Swiss origin and his mother was from a nearby country, and he was born in 1875 in this house. And his younger brother, who became quite influential in his later life. He was initially learnt his compositions from in the Paris Conservatory from 1889 to 95. Around 1902, when Ravel was in 20s, he joined the avant-garde group of artists, writers and musicians known as Apaches, which literally means hooligans. However, despite his considerable talent, he failed 5 times to win the prize of Rome, which was given at that time to support the musicians to come up to a level. And he left the conservatory in disgust, and he vowed that he would not take any French honors since that time. He collaborated in 1920s with the famous Russian musician Stravinsky and became soon an international figure and a master with his own monogram. In 1921, he purchased his first and only house, which is called Les Valais-Vardais, about 30 kilometers from Paris. It was a peculiar house, a boat-shaped house, and Maurice Ravel was a small-statured person. So you see the walls of the house, they are so small, the small utensils, and he used to like these small things, small toys, small instruments, but he was clumsy with big instruments. It was peculiarity. And his house was overlying the forest, and this is his balcony. I used to sit for hours together and compose his beautiful work. Ravel's work was considerable, starting from operas to ballets, orchestral music, chamber music, piano music, songs with instruments. And he was unmarried but not without friends. In 1927, effects of intense creativity was taking its toll. He was advised 1 year rest by his physician, but he continued a triumphant tour of America instead. There was this initial hint of a single lapse of memory during a performance. He continued to work, and in 1930 he wrote a concerto for left hand for an Austrian pianist who lost his right hand in World War I. But alas, nobody would help him when his illness was coming. In October 1932, he was injured in a taxi accident. It was minor. There were minor cuts, and he said, "I was incapable of doing anything else except eat and sleep." In 1933, he conducts his last concerto, Bolero. In 1933, he showed his first signs of ideomotor apraxia, I was showing. He wanted to show the friends how to skim a pebble, but he could not do that. Then he was almost drowned soon, few days later. A famous French neurologist saw him, and he found that Wernicke's aphasia of moderate intensity, understanding of language remains much better with oral and written abilities. Very faulty writing, mainly due to apraxia. Recognition of tunes, tempo and pitch were good, but that of musical notes was faulty. Piano playing was difficult. Musical writing from dictation was very difficult, but music thinking was preserved. Thus he concluded, to conceive is nothing, but to express is all. In 5 years' time, he became a totally demented person. To conceive, but not to able to express is the most painful experience for any artist. And 1933, in speaking about his illness, he said, "The opera is here on my head. I can no longer write my music." And finally, he died following an operation. I'll not go to the details of this, but I'll tell you about this orchestral masterpiece called Bolero, which he wrote, and this is considered to be the masterpiece, but there is an element of perseveration, the repetition which is seen in Alzheimer's disease. So some people suggest that this was basically the product of an Alzheimer's, from a demented mind. Nobody knows about that, and I'll just like to play, if there is 1 minute?
Yeah, 1 minute, exactly 1 minute.
I'll just play this last 1.5 minutes of the film which I made on his Thank you.
I think that's beautiful. I think I'll just take half a second and ask Dr. Sairam to comment. I don't know, what I experienced was probably it was a kind of the life of his that he has actually put in the music, starting from the soothing music to the agitation and the aggression, maybe the frustration in the end.
Yes.
I do not know.
No, the real problem is, even in music, when you go for a very elaborate classical music, you go away from the nature of sounds. Because particularly if you take this Western classical music, I was talking about chord, because while forming a chord, there is so much of mathematical precision to have the right type of frequencies to sound simultaneously. So it is a real challenge, mental challenge for the composer, and not only for the composer, even a person who plays music. He has to be very careful about selecting the frequencies. So there is tremendous tension involved even in playing music. It's not that
Yes.
playing music is going to be therapeutic. So there is a tremendous tension, but over a period we have the ability to withstand the tension. If suppose you are not able to withstand the tension, you have to break in.
So I think that's beautiful, and I think I must really thank both the experts. We've had a very good, I would say, harmony between the music and the neurology because a lot of research still needs to be done, and but still I think music is music, and it does soothe the brain, whatever type of music and in whatever situation, and it must be used for music therapy. And I think we've not had no questions. Normally we always have few questions. So probably it shows how much the students have been engrossed also, because I know they're all there. I've been receiving mails from them right till today morning, and I would request them that whatever questions they have, they can email me so that I can forward them to the two experts for further communication. Thank you.
Thank
Thank you.
Thank you.